Imagine this. You walk into your doctor's office feeling perfectly fine. Your energy is good, you slept well last night, you actually feel healthier than you did 5 years ago. Then the nurse takes your blood pressure, writes down a number, and suddenly you are no longer fine. The doctor wants you on another pill, or higher doses, or both. And you accept it because, well, doctors know best, right? But what if I told you that for millions of seniors right now, that exact conversation is causing more harm than good? What if the number your doctor is chasing is actually making you less safe, not more? Stay with me because I'm Dr. William, and today we are looking at one of the biggest misunderstandings in senior health that is playing out in examining rooms across the country right now. Let me ask you something. Have you ever wondered why blood pressure targets seem to keep changing? Why what was acceptable 10 years ago is now considered high? Why your doctor talks about 130/80 like it is the law of physics when it really is not? Here is the thing that nobody tells seniors in those appointments. Blood pressure guidelines were not handed down from heaven. They were written by doctors who studied mostly younger, healthier people and then universally applied to everyone regardless of age, frailty, or individual circumstances. That is not science. That is assumption dressed up as medicine. Let me take you back. In 2015, something happened in cardiology that changed everything. A massive research study called SPRINT was completed. It followed thousands of people, gave half of them very aggressive blood pressure medications to push their numbers down to under 120/80, and followed what happened to both groups. The group pushed to very low numbers had fewer heart attacks and strokes. So the American Heart Association looked at that study and said, lower is always better, push everyone's pressure down. But here is what got lost in that translation. SPRINT excluded people over 75. It excluded people living in nursing homes. It excluded people with kidney disease. It excluded people with a history of falls. It excluded the exact people we are talking about. These are seniors. These are the people most likely to be on blood pressure medications right now and least likely to benefit from aggressive lowering. Meanwhile, across the Atlantic, the European Society of Hypertension looked at the same evidence and said, not so fast. Yes, high blood pressure is a problem. Yes, we need to manage it. But pushing it too low in older people is a different problem entirely. They recommended different targets based on actual age. For people 65 to 79, aim for below 140/80. For people 80 and older, aim for 140 to 150 on the top number with the bottom below 80. And they specifically warned against pushing below 120/70 because they saw something happening in the research that American guidelines were ignoring. They saw harm. This is where the conversation gets real. When you are 70 or 80 years old, your blood vessels have changed. They have stiffened. This is not a disease. This is aging. Your arteries are like old rubber hoses. They do not expand and contract the way they used to. When medications force your blood pressure down to very low numbers with stiff, inelastic vessels, something unfortunate happens. The pressure inside those vessels drops too much. Blood flow slows down. And three organs that absolutely depend on steady, strong blood flow start to suffer. Your brain, your heart, your kidneys. Think about what happens when you stand up. Your heart needs to push blood all the way up against gravity to keep your brain conscious. When blood pressure is normal and vessels are healthy, this happens automatically. But when blood pressure is artificially suppressed by too much medication and your vessels are stiff, that push is not strong enough. You stand up and suddenly the room spins. You get dizzy. You might fall. And if you have osteoporosis, a fall at 75 is infinitely more dangerous than a heart attack that might be prevented by a lower blood pressure number years from now. We are trading a theoretical future benefit for an immediate current risk. And most patients have no idea this trade is happening. The second organ is your heart itself. Here is something that most people do not understand. Your heart is a muscle. Muscles need blood flow. The coronary arteries that feed your heart muscle do most of their feeding during the relaxation phase between beats. That relaxation phase is what we call the diastolic number, the lower number in your reading. When that number gets pushed down too low by aggressive medication, something called the J-curve effect starts to happen. Risk is high when blood pressure is very high. Risk drops as you bring it down and control it. But then something unexpected happens. As you push the diastolic number down further and further below 70, risk starts to rise again. The curve looks like the letter J. The heart is not getting enough blood during those critical relaxation moments. We are seeing more heart attacks in some subgroups of older patients on very aggressive therapy, not fewer. This is not theoretical. The research is there. In 2024, major reviews published in the European Heart Journal and Hypertension journals specifically documented cases of older adults who experienced harm from blood pressure being pushed too low. People who got dizzy and fell, people who had heart events, people who experienced cognitive decline because their brain was not getting adequate flow. The European Society of Hypertension specifically lists these complications and recommends more conservative targets for older people specifically because of this evidence. Now, here is where it gets really interesting. Ask yourself this question: who benefits most from the newest, most aggressive blood pressure medications? Who is most likely to have those medications prescribed? It is not young, healthy people with insurance companies questioning every prescription. It is older adults, seniors, the population least likely to benefit and most likely to experience harm. Why? Because the guidelines that came from studies that excluded them are still the guidelines being used to manage them. And the doctors following those guidelines are acting in good faith. They are trying to follow the standard. They are not trying to harm anyone. But good intention does not equal good outcome when the standard itself does not fit the population. Let me give you a concrete example. You are 78 years old. You have mild arthritis in your knees. You had one fall last year, nothing serious, but it shook you up. You have some narrowing in your arteries, nothing severe enough to need intervention yet, but it is there. Your blood pressure has been running around 145/78. Your doctor says we need to get you below 130. They increase your medication. Now your pressure is 118/65. You feel fine at first, but then small things start happening. You get up too fast and feel dizzy. You reach for something on a high shelf and lose your balance for a second. You have a moment where you cannot quite remember where you put your glasses and it panics you. Are these side effects? Are these normal aging? Are these signs of medication going too far? You do not know. And increasingly, doctors do not know either because they are not trained to ask these questions. They are trained to hit a number. The data from 2026 is even clearer than it was 5 years ago. Research from multiple countries shows that older adults prescribed unnecessarily aggressive blood pressure medications have higher rates of falls, higher rates of dizziness and fainting, higher rates of acute kidney injury, and in some subgroups, higher rates of cardiovascular events. We are medicating a number instead of treating a person, and the person is paying the price. But here's what I want you to understand. This is not about telling you to ignore your blood pressure or stop taking medications. High blood pressure is genuinely dangerous. Uncontrolled high blood pressure damages your vessels, your heart, your brain, and your kidneys. That part is true and important. What is not true is that every senior with a blood pressure reading above 130 needs the same treatment, the same target, or the same medication intensity. What is not true is that lower is always better. What is not true is that this should be one size fits all. The real science, the actual evidence that is published in major cardiology journals right now supports something different. It supports individualization. It supports looking at who you are, not just what your blood pressure number is, your age, your medical history, whether you have had falls, whether you have heart disease, whether you have kidney disease, whether you are frail, whether you are on 5 other medications, whether you have a history of dizziness. all of this matters more than hitting a specific number for a population that was not included in the research that created that number in the first place. I see this in my practice constantly. A patient comes in on 3 blood pressure medications. Their pressure is 118/62. They are dizzy. They fell last month. They cannot concentrate. And I ask the simple question that apparently nobody else has asked. Why are we doing this? What is the goal? What are we protecting you from by keeping you at a number that is making you fall down the stairs? We back off the medications. Their pressure comes up to 140/75. The dizziness resolves. The falls stop. Their cognition improves. Their quality of life improves. And here is the part that interests me most. Their cardiovascular outcomes do not get worse. Sometimes they get better because they are moving more, they are exercising more, they are less afraid of falling, and they are less dependent on medications that were never indicated in the first place. Now, let me talk about something that almost nobody discusses with older patients, but absolutely should. The diastolic number, the bottom number, 120/80. Everybody focuses on that 120, but that 80 is probably more important for you if you are over 65. Your diastolic number determines how much blood your heart receives during the resting phase. If that number is too high, yes, that is a problem. But if that number gets pushed down too low by medication, that becomes a different problem entirely. Studies consistently show that in older adults, particularly those with existing heart disease or kidney disease, a diastolic number below 60 is associated with worse outcomes. A diastolic number below 70 is associated with increased risk in certain populations. And yet, patients come to me on medications that have their diastolic down to 55. No wonder they feel terrible. No wonder they are falling. We are not giving their hearts adequate blood during the one phase of the heartbeat cycle where the heart itself is supposed to be getting fed. This is not controversial. This is not my opinion. This is documented in research from the American Heart Association, the European Society of Hypertension, the European Society of Cardiology. It is there, and most patients over 65 have never heard it mentioned once. So what does this actually mean for you? If you are sitting at home right now on blood pressure medication and you have blood pressure readings recorded somewhere, I want you to start paying attention to both numbers, not just the top number. The bottom number matters. Specifically, I want you to track for 2 weeks whether your diastolic number is regularly below 70. If it is, this is the conversation to have with your doctor. I also want you to notice something else. When are you dizzy? Is it after you take your medication? When you stand up quickly? Is there a pattern? Keep a simple log. Blood pressure reading, time of day, any dizziness or lightheadedness, any near falls or actual falls. This information is gold for your doctor because it connects the medication to what is actually happening in your life instead of just abstractly looking at a blood pressure number. And here is the biggest thing. Ask your doctor 3 specific questions at your next appointment. First, given my specific age, my specific health conditions, and my specific history of falls or dizziness, what blood pressure target is right for me, not for the general population? Second, what is my diastolic number right now, and is it staying above 70? And third, what would actually happen if my blood pressure came up to 140/80? What specific harm would that cause to me personally, given my personal risk factors? Not theoretical harm, not population-based harm, but to you specifically. Most doctors will pause when you ask that third question because the honest answer in many cases is, I do not know. We are just following the guideline. And that becomes a conversation about whether the guideline actually applies to you. Now I want to talk about something equally important. What can you actually do about this? If you are on blood pressure medication and you are concerned about being over-medicated, what is the move? First, do not just stop medications. Do not do that. Blood pressure medications, when they are indicated, keep you safe. The question is whether they are indicated for you and at what intensity. What you can do is lifestyle. This is where real sustainable blood pressure management actually happens. Daily movement, not intense exercise that puts stress on your body. Gentle, consistent movement. Walking 20 to 30 minutes a day has been shown to lower blood pressure as effectively as some medications, and it does not cause dizziness, it does not cause falls. It makes you stronger, not weaker. Diet matters. The Mediterranean diet, the DASH diet, these are not restrictive fads. They are patterns of eating that genuinely reduce blood pressure while improving overall health. Not by cutting salt to nothing, which most older people with arthritis or other conditions actually struggle with anyway, but by adding more vegetables, more fish, more healthy fats, by reducing processed foods. These changes take time. They do not work overnight, but they work. Sleep quality. Blood pressure is intimately connected to how well you sleep. Stress management. Chronic stress drives blood pressure up. Consistent meditation or simple breathing exercises, even 5 minutes a day, lower blood pressure measurably. These are not alternative medicine. These are documented in the same journals that publish the medication studies. The people who see the best results do not do one of these things. They do all of them consistently. They walk every day. They eat better most days. They sleep with a regular schedule. They manage their stress. And then they need less medication. Sometimes they need no medication. But this is not quick. This is not dramatic. This is the opposite of the message most people get when their blood pressure is high, which is that you need a pill to fix it immediately. Now, I know what some people are thinking. You are a doctor. Are you saying doctors are getting this wrong? Am I saying do not listen to your doctor? No. I am saying listen to your doctor, but also bring current research to the conversation. I am saying your doctor got their training at a particular time, and the guidelines change, the research evolves, and sometimes the guidelines that were cutting edge when they were published have been refined or clarified by newer research. That is not your doctor being wrong. That is how science works. We get better information and we adjust. There are absolutely older adults who benefit tremendously from aggressive blood pressure lowering. If you are 70 years old, completely healthy, no falls, no dizziness, no heart disease, no kidney disease, and you tolerate medications well, getting your blood pressure down to 120/80 might be appropriate for you. The guideline is not inherently wrong for that person. It is wrong when it is applied universally to everyone without asking the individual questions that the guideline itself says to ask. Here is what I want you to take away from this. Your blood pressure matters. Controlling it matters. But how it is controlled matters more than what number it ends up being. A blood pressure of 145/78 achieved through daily walking, a good diet, stress management, and minimal medication is safer and better for many older adults than a blood pressure of 118/60 achieved through heavy medication that makes them dizzy and fearful of falling. The goal is not the lowest number. The goal is a number that protects your heart and brain from damage while maintaining adequate blood flow to those organs. The number that lets you move freely without dizziness. The number that lets you live your life without fear of falling and breaking your hip. The number that is right for you as an individual with your specific circumstances. And that number might be higher than what a universal guideline says it should be. That conversation, that individualization, that is what modern cardiology should be. That is what the best research actually supports. And if your doctor is not having that conversation with you, you need to bring it up. I want to do something different here. Rather than pitching you something to buy, I want to give you something to do. Over the next week, I want you to collect 3 pieces of information. Your blood pressure readings, both numbers, any symptoms you experience like dizziness or falls, and one honest conversation with your doctor about whether your current target is actually right for your personal situation. Just those 3 things. Then come back, let me know what that conversation looked like. Comment below. Tell me what your doctor said when you asked about your specific situation instead of the general population. Tell me if this video changed how you are thinking about your numbers. Tell me if you discovered something about your diastolic number that nobody had ever mentioned. I read every single comment, and the comments become the next videos because I teach based on what you are actually asking. If you found this valuable, subscribe. Not because I need subscribers, although I do, but because if this resonated with you, there are 12 more videos on this channel about senior health that you probably should see. Videos about medication interactions, videos about exercise that is actually safe at your age, videos about the confusion around salt and blood pressure, videos about heart disease risk in older women that nobody is addressing. Subscribe so you do not miss those. And if you know someone over 65 who is on blood pressure medication and has never had a conversation about whether it is actually appropriate for them individually, share this. That person might be experiencing side effects from something that was never indicated in the first place. That person might be unnecessarily dizzy and fearful of falling when they could be living fully. Share it. That conversation could change their life. I am Dr. William. Your health is not a number. It is a life, and that life is what matters. Take care of yourself. Important disclaimer. Everything shared in this video is educational information based on current published clinical guidelines, including the 2024 European Society of Cardiology guidelines, the 2023 European Society of Hypertension guidelines, and current American Heart Association recommendations. These guidelines acknowledge that individual patient situations are complex and require personalized assessment. This video is not personal medical advice. Do not change, adjust, or stop any blood pressure medication based on this video alone. All medication decisions must be made with your own physician who knows your complete medical history, your current medications, your kidney function, and your individual risk factors. This video is a starting point for that conversation with your doctor, not a replacement for it. If you experience new dizziness, falls, or concerning symptoms, contact your doctor immediately rather than making changes on your own.